Hello.
Yes, we can hear
Yes,
you. We can hear you.
okay, okay. All right. So I'll be talking today on the physiology of puberty. Also wanted to add chlamydia and menopause, but that will make the session today too long, and it's better to take them in sections. So this will also lead to talking about the different staging, of pubertal development as well. And some of the interesting questions that I like asking, which is first, which is the first physical sign and all the rest. So as a way of introduction, puberty usually is a period when the endocrine and gametogenic functions of the gonads, attain the point where reproduction can take place. From birth until they are activated by gonadotropins, the gonads remain quiet. In females, that would be the remaining gonads, because by the time a woman reaches that age, you have just about 4 to 500,000 ovums that are left in the ovary. So it is the period of final maturation, of the gonadal system, and this period in which there is a transition from sexual immaturity to adolescence and adulthood, and is characterized by some very dynamic changes both in the body, both on the outer part of the body and also on the inside. And then there is also physical, emotional, psychological, behavioral, as well as sexual change at that time. You know, um, the age of puberty, as it varies in different localities. But puberty generally starts from around 8 years in those that are earliest, and in some places it can be as late as can start as late as 13 years. So the adrenal androgen secretion, which increase during puberty, refers is what we call adrenal K, and it has been seen that that is what is responsible for puberty. And there is usually the type of androgen that is found mostly is the dihydroepiandrosterone, which is DHEA. So some of the factors that influence the puberty, include genetic composition of the individuals. In certain individuals, puberty comes far much in the lower range that I projected, and in some it comes at the higher range. Other things include racial predilections, like black females attain puberty earlier than white females, and then nutrition, where children that are well nourished, go on to have early puberty compared to those that are malnourished. And then exercise plays an important role. For instance, in athletes where they do extreme exercise, that tends to delay puberty. Childhood obesity has been seen to be linked to early puberty, and health status, which I've talked about before, and exposure to light. It has been actually been shown by research that blind girls attain menarche far much earlier than those who are not blind. And then the physiological state, lack of a father figure, loss of either parent, all these have been seen to delay puberty. And then the geographical location, children who live in urban settings and closer to the equator and at lower altitudes tend to begin puberty much earlier than those who live in rural areas, and especially those that are farther also from the equator and at higher altitudes. Sorry. About 10 to 20% of children population also stand the risk of early puberty without any identifiable reason. That's the case where we can refer to those kind of early puberty as idiopathic. Some of the hormonal changes that occur, you know, um, are the results why puberty starts, and the result why puberty is delayed in some people. It has now been known that a neural mechanism is responsible for the initiation of puberty. The onset of puberty, however, depends on the normal functioning of the hypothalamus, the pituitary, and the gonadal axis. It's believed that from birth to puberty, a neural mechanism is prevents the normal pulsatile release of gonadotropin releasing hormones. However, this has not been fully elucidated, and recent studies suggest a gene for a calcium protein coupled receptor, and has been said to be involved in this. The reactivation of this axis actually leads to sexual maturity and the process of menopause. So what happens is that the central nervous system inhibits the onset of puberty until the appropriate time and the appropriate weight, appropriate conditions are met, and then that's the gonadotropin releasing hormones, secretory neurons, which are found in the arcuate nucleus of the medial basal hypothalamus, has been known to be the pulse generator. Now there is a need for a pulsatile release of those hormones, as the follicle stimulating hormone and the luteinizing hormone. There needs to be a pulsatile release at a certain frequency for it to allow the initiation of puberty. So this just close to puberty, this begins to happen at night, but as puberty gets much more closer, it begins to extend to daytime, and then the frequency is actually increased. So once the LH and FS secretions begin to be secreted in this pulsatile manner, then puberty is bound to happen. Now, for the first 1 or 2 years of this secretion, this occurs in an uncoordinated manner, but between 5 to 10 years, there is a coordinated pulsatile release of GnRH, which eventually leads to FSH release in a similar pattern. And then also an hormone which is produced by adipose tissue, leptin, has also been shown to be to be implicated in the onset of menopause. Now, this hormone, it has been found that if a woman is not up to a certain critical weight, usually the weight is around 49 kg, that puberty would not begin. And that is why athletes that lose weight can even stop menstruating because of this problem. And even patients that suffer from anorexia and nervosa. Therefore, it has been shown that leptin is linked, to puberty. So some of the physiological changes that occur at puberty, includes, let me just list them out. Telarchy, which is the development of the breast; menarche, which is menstruation; adrenarche, which is the development of the pubic and axillary hair; and then as well as the growth spots. So there are about 5 things that occur, at the time of puberty. And the very first thing that happens, to signal puberty is usually the growth spot. However, usually not really the growth spot per se, but production of androgens at the adrenal glands. However, the very first noticeable sign of puberty in girls is usually the development of the breast, which is where I'm going to start from. So for breast development, this is usually the first physical sign. It occurs at around 10 to 15 years in women, and there are about 5 stages, which was described initially by Marshall and Tanner, and which is now named as the Tanner staging of breast development. I think I must apologize here that I forgot to, at the end of the day, put up some pictures, but I'm going to describe it in such a way that it will be easily, identified which stage. So for the pre-adolescent stage, in this stage, there is only the elevation of the breast papilla only, and the areola in this case is less than 2 centimeters. Now, this is what occurs in the prepubertal girls. However, in stage 2, there is the appearance of the breastbud, just a small elevation around the level of the nipple, although that breastbud is still not enough to call it a nipple at that stage, but it's just beginning developing a nipple at that stage. So that elevation of the breast and papilla are small mounds with enlargement of the areola and the thinning of its skin. And at this point too, the nipple also begins to develop. So this stage just differs from the stage 1 just by a few just by an elevation which includes both the areola in this case and then the nipple which is developing. Then in stage 3, there is enlargement and elevation of the breast and areola. Now, there is no separation of the contours in stage 3. Everything just develops The areola together, the areola area and some small areas around the areola is raised up. And then the nipple tend to lie, at the top, almost at the center of this, but it's almost as if it's pointing up. Now, in stage 4, this is the stage of the secondary mound. Only the areola now in this case and the papillae of the breast, which includes the nipple, projects as a secondary mound on top of the breast tissue that has already developed. While in stage 5, the secondary mound disappears and gives way to the normal adult breast. The process usually takes around 2 to 3.5 years. So the other thing that also happens at puberty is the puberty, which is the period of development of the pubic and axillary hair, the process of development of the pubic and axillary hair. And this also has 4 stages. That is in terms of description of the pubic hair. Now, the stage 1 in development of the pubic hair includes that the pre-adolescent. In this, the major thing about this standard staging of pubic hair development just has to do with development in terms of quantity and then the color or the type of hair that is being developed. Now, in stage 1, which is the pre-adolescent stage, there is no pubic hair, but some non-sexual hair may be seen in that genital area. Now, for stage 2, there is sparse hair growth along the labia, which is long. It can be slightly pigmented and can be straight or slightly curved. And it usually occurs around between 8 to 14 years. At stage 3, the hair becomes darker, more coarse, and more curled hair and grows sparsely over the mons pubis. By stage 4, you already have the adult type of hair in thickness and texture, but the distribution, the extent of the hair is not as much as in the adults. While in stage 5, the hair extends both to the thigh and the abdomen in the typical form of the women, which is an inverted triangle. Now, the next thing that occurs is the growth spot. And this growth spot just is the increase in height for the woman. The growth rate in infancy is usually very rapid. It can occur around 15 cm per year at 3 to 4 years, but this begins to slow down as the child begins to reach around that menopausal area. Now, the lowest rate occurs around 18 to 12 to 18 months preceding puberty. But however, at puberty, there is a growth velocity that occurs again of around 10 cm per year. And usually the child may gain around 2.5 meters in height during this period. And for girls, this ends much earlier than in boys. About 2 years, it ends at 2 years earlier than in boys. So by the time the epiphysis, because the estrogen that drives this growth also drives the fusion of the epiphysis. So once the epiphyseal plate have already fused, there is no more growth that occurs. So there is also increase in bone density at this period as well. And then this is a result of the growth hormone, insulin-like growth factors, estradiol, as well as thyroid hormones. All these play a powerful role in this growth spot that occurs. And then the other thing that also happens is adrenal, which I described earlier as the process where there is increased production of the adrenal androgens. I think I made a mistake with this because I think I mentioned that in place of puberty, which is actually the development of the pubic hairs. But adrenal is the process of increased secretion of the adrenal androgens. Androgens are the male hormones which drive most of the process of puberty. And the hormones that are increased, that are secreted more, includes the diepiandrosterone and dihydroepiandrosterone sulfate. So those hormones are produced in increased numbers, and they are what is responsible for some of the pubertal signs that are seen in women. Then also one of the things that also happen, the final thing that occurs in puberty is menarche. That is the first menstruation that a woman has. It is a critical milestone, for a lot of reasons, medical, sociocultural, and even the sexual, characteristics of these women. Once a woman has seen her first menstrual period, the likelihood of becoming pregnant at that point is higher because it shows that the ovarian and the, uterine cycles, have started to get in sync. And the age at menarche has been identified as a risk factor in many conditions, including things like breast cancer, cervical cancer, and other conditions that can, affect women. It is known that relative timing of menstruation affects engagement in risky behaviors, especially during the adolescent years. Age at menarche actually varies globally. However, by the time a woman is up to 14 years, and she has not menstruated, that is in a woman who has already started having other sexual characteristics, then that patient should actually be evaluated because there might be problems. If by the time she's 16 years old and then she has still not she has not even had any other sexual characteristics, then there is also a problem with that lady, which is just what this slide is just talking about. And then I'm also going to, okay, it's also good to say that about 80% of the menstrual flow in the first year of the woman attaining menarche is usually without ovulation occurring. While 50%, this begins to decrease and a woman starts having, ovulatory cycles. By the third year, she has about 50% anovulatory cycles. And by the sixth year, this has reduced to as little as 10%. So, however, most girls must also be stressed that where there is a rule in medicine, there is also an exception. Some girls can ovulate even before they see their first menstrual period. So, if at any point they engage in sexual activities at that point, they may also be able to get pregnant. And then the onset of menarche, premature menarche, as I've already said, the age cutoff for menarche is 14 years in a woman who has already started having other signs of puberty. However, in women who are 16 years old who have not seen any other sign of puberty, that also becomes, so there are two critical ages: 14 for those who have seen their menses, and then 16 years for those who have not yet seen other signs of pubertal changes. I'm sorry about that. So it's good to note that there is something that can occur like a premature menarche, which occurs before 14 years. In some girls, it can occur in as early as 12 years old. And then primary amenorrhea, amenorrhea is said to have occurred when a girl has not seen her period after 3 years of breast development, or as I said before, after 16 years of no sexual characteristics or no secondary sexual characteristics. So there are changes that occur in the vagina, the uterus, and then the ovaries. The pubertal changes seen in these organs, they are actually due to estrogen effects. So let me start from the skin. The skin around the perineum becomes darker, during the time of puberty, and then the skin of the vulva becomes thicker. The labia minora grows larger at this point, projects beyond the labia minora, the labia majora, sorry. And then there is production of melanin, pheomelanin in this case, which causes reddening of the labia minora. And then the vaginal mucosa becomes thicker and multi-layered. It becomes many layers. You have many layers of the squamous stratified columnar epithelium non-keratinized. And then there is increase of myoepithelial cells, and also increased production of things like glycogen in this vaginal mucosa. And then and that is why there is production of the lactic acid that nourishes some of the bacteria that are found there. And then there is also a disproportionate increase in the in the uterus. Now, in the prepubertal age, the ratio of the cervix to the body of the uterus is about 1 to 1. In some cases, even 2 to 1. In this case, the cervix can be larger than the body of the uterus. However, in girls of in girls that have reached puberty, the body of the uterus begins to grow in such a way that the ratio will now be reversed. The body can be 2 times the size of of the cervix, or in some cases 3 times the size of the ovary, the size of the cervix. Sorry, and then the ovaries.
Sir, please, we can't see your screen.
You can't see my screen again.
Yes, sir.
Hello. Eh?
Yes, we can't see your
Okay.
screen.
Okay. Let me see. Sorry. All right, I'm sharing now. Can you see now?
Yes,
Hello.
sir. Thank you, sir.
Okay. So as I said, the ovaries also increase in size at this time, and then there is an increased distribution of body fats, to some of the areas, the hips, and then around the abdomen and the breast. Development of the body fats to those areas. Then some of the disorders that occur during puberty includes things like precocious puberty, delayed puberty, and premature. You can also have all the different, components of puberty can have the different, can have problems with each of them. I can have premature adrenarche, can even have absence of the puberty in total, and then menorrhagia of puberty, that's excessive bleeding during puberty. I'm just going to talk on precocious puberty as well as delayed puberty. So precocious puberty occurs when the secondary sexual characteristics occur before the age of 8 years old. And you know, the main thing, as I said before, is the occurrence of menarche, and the occurrence of menarche before age of 10. So if by 8 years old, most of the sexual characteristics have already occurred, and that child is termed as having precocious puberty. And those kind of girls are, because they don't really understand themselves at that point, they are at risk of sexual molestation and all sort of things that can happen. There are actually two types: the true precocious puberty, which is gonadotropin dependent, dependent on the axis, while the precocious puberty, the pseudo puberty, is not dependent on gonadotropin. So for the gonadotropin dependent, usually due to an early activation of the hypothalamic pituitary ovarian axis, is more common, with a prevalence of about 1 in 5,000 to 1 in 50,000, and about 80% of them are idiopathic. But the causes other than idiopathic causes include the hypothalamic hamartoma, that's collection of tissues in the hypothalamus, a glioma, which is a tumor in the brain, an astrocytoma, which is also a tumor in the brain, geminoma, meningioma, all tumors in the brain. Then all other things that can cause it include traumatic brain injury, and then encephalitis. What this does is that they all, you know, deactivate this rhythm of the hormones in such a way that they deactivate and allow the hormones to begin to be produced in a pulsatile manner, and therefore trigger puberty. Now, the gonadotropin, non-dependent precocious puberty, occurs in situations where there is no spermatogenesis or ovarian development. Precocious puberty occurs independently of the axis, as I said before, the hypothalamic pituitary gonadal axis, or there is inappropriate exposure to estrogen or androgen. And usually these are at the target organ. The target organ in this case is the ovary. When things that are targeting this organ, lead to increase in secretion of estrogen or androgens, that child may have precocious puberty. In a child who is taking oral intake or even parenteral estrogen or androgens, that child can also have precocious puberty. So other causes of precocious puberty also include the administration of androgens or estrogen, adrenal tumors producing gonadal steroids, or disturbance of the steroid synthesis, even in the adrenal gland, then hormone secreting tumors, or the liver and the ovaries, Leydig cell tumors, which produces androgen, as well as McQueen Albright syndrome. So some of the diagnosis of this is based on history, physical examination, and relevant investigations. For the idiopathic or true precocious puberty, which is seen in 80% of the cases, history of early sexual development in the sibling or the mother might be a pointer to that. The history of pubertal changes, which correlate with the normal sequence. However, the timing is earlier. So in a way, the growth spots begin, and then followed by the telarchy, adrenarche, puberty, and then menarche. However, the timing is earlier. Now, the other thing that occurs is that you can have gonadotropin. For the gonadotropin dependent history of CNS lesions such as meningitis, convulsions, head injury, or papilloma or papilloedema, history of exposure to exogenous estrogen or androgens. And then for the physical examination, pubertal changes which are more advanced than expected for the age, clinical features of organic lesions in the brain, and then brittle bones or cartilage spot in cases of McQueen Albright syndrome. So investigations usually tailored to the clinical findings. Pelvic ultrasound can be done if there is ovarian pathology suspected. X-ray of the hand and wrist in evidence of accelerated growth from the growth spot, and then skull X-ray to exclude intracranial lesions. Follicle stimulating hormone or LH can be done, and then estrogen and testosterone can also be done. This to see their levels, so which will tell us at what level the problem is. If there is increased follicle stimulating hormone and luteinizing hormone, while there is decreased estrogen and testosterone, that tells us that the problem is at the ovaries, and as such, the hypothalamus is trying to compensate by producing more FSH and LH, but the ovaries are not responding. If on the other hand there is increased estrogen and testosterone, and there is reduced follicle stimulating hormone and LH, that tells us that the problem might be a hormone secreting tumor from the ovary, and this is causing feedback inhibition on the hypothalamus. Now, on the other hand, if we have decrease in both the follicle stimulating hormone and testosterone, as well as estrogen, that problem is likely from the hypothalamus. So other things that can be, sorry, I'm coming. Okay, sorry, I had a little challenge with my phone. So other things that can be checked for includes the, vanimandelic acid, as well as hydroxy and progesterone, which are all metabolites in the pathway of steroid synthesis. And these steroids are what are eventually leads to androgen and then estrogen. So treatment usually depends on the identifiable cause. And then it's very important to protect these children from sexual abuse, and to prevent premature closure of the epiphysis, to suppress the premature activation of the hypothalamo-pituitary ovarian axis. And then drug treatment for precocious puberty should be discontinued at the time puberty is expected. As in, once you get up to around 11, 12 years old, the drugs that were suppressing this attainment of menarche and other signs of puberty can now be discontinued. So treatment options include withdrawal of the exogenous hormones in cases where the child is mistakenly taking exogenous hormones, surgical removal of a tumor in the brain if that's what's causing the problem, use of gonadotropin releasing hormone agonists. This allows the suppression of the pubertal changes. So if there's some changes that already occurred, you can, suppress the other changes till a time when you were actually expecting puberty in this child, and then you can now remove the hormone and allow them to have, their puberty. Also, medroxyprogesterone acetate and danazol can also suppress further development of the ovary. So the other thing I just want to touch on briefly is the delayed puberty. So puberty, as I said, is delayed in girls when there is failure of secondary sexual characteristics, usually by age. Some people put it at 13, but the cutoff age should be 14. And then failure to menstruate by age 16. In this case, there is no menstruation and there is no other sexual characteristics and secondary sexual characteristics. And failure to menstruate 5 years following the onset of puberty. So some of the etiological factors, that cause this, I will put it as hypergonadotropic hypogonadism, which is what I explained earlier. In this, the gonadotrophic hormones include the follicle stimulating hormone FSH and LH. In this instance, they are produced in higher quantities by the hypothalamus. However, the problem appears to be with the target organ, in this case, the ovary.
So
So there is no
we
production.
can't see your slide anymore.
Again, okay. Sorry, let me just go back to that. Hello, are we there now? Hello, hello.
Yes,
Are the slides there now?
yes,
Yes,
yes.
sir. Yes, sir.
Okay. So, as I said, this etiology for delayed puberty is, divided into the hypergonadotropic hypogonadism. In this case, you have high levels of FSH and LH, but low levels of estrogen and testosterone, which, tells us that the problem is with the ovary. And some of the causes include Turner syndrome, in which the ovaries are not well developed, gonadal dysgenesis, in which the ovaries are also not well developed, exposure to radiation, which can damage the ovaries, as well as chemotherapy, which can also damage the ovaries. And then in hypogonadotropic hypogonadism, in this case, the problem is from the hypothalamus. There is no compensatory, production, secretion of FSH and LH, so everything is reduced. FSH, LH, estrogen, and then androgens are all reduced. So this can occur in chronic illnesses, severe malnutrition, thyroid disease, anything that can suppress the hypothalamic productions can cause this Kalman syndrome, as well as craniopharyngiomas. And then there can also be problems in which there is no problem with the gonads. So this is also called the eugonadic hypogonadism, eugonadic delayed puberty. In this case, it's just a problem with the outflow tract. For instance, problems with things that imperforate hymen. In this case, there is development, but however, and then there is menarche, but there is no outflow of the blood because the blood is, retained in the uterus and in the vagina because of problems with the outflow charts. In this case, an imperforate hymen can cause that. A transverse vaginal septum can cause that. Androgen insensitivity syndromes can cause that. And then finally is the treatments of delayed puberty, counseling the parents on the clinical findings. If the child is malnourished, you correct, because as I said before, if the weight has not, a good weight is not achieved in childhood, it might delay puberty. At least a child should develop to the age of at least 49 kg for puberty to be able to develop. And then the appropriate treatment of a chronic illness, if that's what is found. Hormone replacement therapy, in this case, the corresponding hormones can be given. In this case, estrogen or androgens can be given, to ensure the development of the secondary sexual characteristics. And then for structural anomalies like the outflow tract problems, appropriate surgical interventions, can be done. And then gonadectomy in cases of androgen insensitivity syndrome. In this case, the girl is actually a boy, XY. However, because of the insensitivity of the end organs to testosterone or dihydrotestosterone, the child develops as a girl, but in reality, genetically is a boy. So in this case, you have to still go ahead and remove the strict gonads because cancer can develop, from them. So that is just what I want to bring up today. However, the most important thing to note is, the sequence of the changes. The very first thing, as I said, is the growth spot that starts first. No, sorry, not the growth spot, the adrenarche, which is the, increased production of androgens. And then that is usually followed by the growth spot. And then, however, the first physical sign that most people notice is the breast development, which is called telarche. And then that is followed by puberty, and finally by menarche. So that is where I'm going to draw the line. If there are any questions, I will take them as they come. Thank you very much.
Thank you, Shikubon. Please, do you have any question for? Okay, in absence of any question, we say thank you very much. We do appreciate the lecture.
Okay.